Okay, good afternoon, everyone. Welcome to lecture 53 of BMS 300. Right. So today we are going to do the PollEverywhere questions from the urinary system, and then once we are done with that, we'll just continue doing more PollEverywhere questions on the digestive and also the respiratory system as well. All right. So I hope this is just a chance for you to review what you already have had a chance to practice on your own time. So let's get started. Which of the following events helps to maintain the medullary osmotic gradient in the peritubular fluid? Right, so the focus is on the peritubular fluid, and the question is, which of the events will help to maintain the osmotic gradient there? Is it the tubular reabsorption of sodium chloride ions in the ascending nephron loop, or is it in the tubular reabsorption of urea, which happens in the papillary duct, or is it the tubular reabsorption of water in the descending nephron loop, or the tubular reabsorption of urea in the distal convoluted tubule? Okay. Okay, so most of you said the tubular reabsorption of water in the descending nephron loop, right? So we see that the right answer is actually B, which stands for the tubular reabsorption of urea happening in the papillary duct. So if you look here, we see that the peritubular fluid is the fluid which is surrounding the nephron, right? The fluid inside the nephrons, mainly the nephron loop and the distal convoluted tubule, all of that, it's going to be the filtrate. And so in the peritubular fluid, we find that in the deepest part of the medulla, we find that it's got a very high concentration, and that high concentration is due to urea moving from the papillary duct into the peritubular fluid. Now the reason why urea moves at the papillary duct into the peritubular fluid is that all along the nephron loop, right, the descending limb, the ascending limb, and then moving on to the distal convoluted tubule down to the collecting duct, all of it is impermeable to urea. So urea is just going to be increasing in its concentration as it moves down, and finally it gets to exit from the papillary duct into the peritubular fluid. And that is why, as far as the peritubular fluid is concerned, it is the tubular reabsorption of urea which happens in the papillary duct. Is this clear, folks? Whereas, the descending limb of the nephron loop or the distal convoluted tubule, they don't play a role in influencing this urea movement into the peritubular fluid to increase the overall concentration. Can we move on to the next one? Yes, okay. So while examining histology slides of the kidney, you find simple squamous cells in the blank. So do you find them in the proximal convoluted tubule, or in the distal convoluted tubule, the glomerular capsule, or in the papillary duct? Where would you find simple squamous epithelial cells? Okay, most of you picked glomerular capsule, and that is correct. So this is a slide showing you how the different parts of the nephron have different names because they have different functions, and they have different functions because they are made up of different types of epithelial cells. So we find that it is in the glomerulus where you will have the glomerular capsule made of simple squamous epithelial cells. Also in the descending limb of the nephron loop, also you have simple squamous epithelial cells, right? Whereas in other parts it's mainly simple cuboid epithelial cells. Notice that in the papillary duct you have columnar cells, but otherwise it's mainly simple cuboidal epithelial cells. And so this is how you find the answer, right? it's in the glomerular capsule where you have the simple squamous epithelial cells. If there was the nephron loop mentioned, then more than one answer would be correct. Okay, moving on. The chloride and bicarbonate transport that occurs in the distal convoluted tubule and in the erythrocytes is an example of what? So there is chloride and bicarbonate transport which happens in the distal convoluted tubule and in the erythrocytes. What is this an example of? Is it an example of co-transport, facilitated transport, counter-transport, or exchange pumps? Okay, most of you picked counter-transport, and that is correct. So we find that the transport of the transport of chloride and bicarbonate ions will take place where one enters into the cell and the other one is leaving, right? So that's an example of counter transport. This not only happens in the red blood cells, but also it happens in the nephron as well, right, to help in the movement of ions across the membrane. So next question, when there is an decrease in the glomerular filtration rate, which of the following responses do you think most likely will occur in autoregulation, right? So there's going to be a decrease in the glomerular filtration rate, and as a result autoregulation steps in. So which do you think will happen? Will there be a constriction of the efferent arteriole, or would there be a constriction of the juxtaglomerular cells, or would there be a relaxation of the macula densa, or a constriction of the afferent arteriole? Okay, most of you picked constriction of the efferent arteriole, and that is the correct answer. So we see that the juxtaglomerular complex is going to involve these three types of cells, and the main goal of autoregulation when there is a drop in the glomerular filtration rate is to increase the glomerular filtration rate by first allowing more blood to move to the glomerulus, first step, and second step, it's going to ensure that less blood is being taken away from the glomerulus. So by having more blood coming to the glomerulus and less leaving, that will increase the glomerular filtration rate. So there has to be a relaxation of the afferent arteriole which brings blood to the glomerulus, but the efferent arteriole which takes blood away from the glomerulus, that is going to constrict, right, so that you have less blood leaving. And the other two options won't work. There would be also the macula densa cells shown here. They are going to they don't really constrict, and the extra mesangial cells will constrict as well. So is this clear why the answer is option A? Okay. Okay, when there is a drop in blood pressure or low blood volume, the conversion of angiotensinogen to angiotensin 1 would be brought about by which of the following? Is the conversion from angiotensinogen to angiotensin 1 brought about by renin, angiotensin converting enzyme, also known as ACE, aldosterone, or vasopressin, also known as the antidiuretic hormone? So these four hormones, I really hope you know what their functions are, because there will be multiple questions which we will be considering on these in today's class. Okay, most of you picked renin, option A, and that is correct. So you'll notice here that renin is produced by the juxtaglomerular cells when there is a drop in blood pressure, or maybe a decrease in the solute concentration, decrease in sodium concentration. And as a result, we find that renin will convert angiotensinogen produced by the liver into angiotensin 1. And then angiotensin 1 will be converted to angiotensin 2 by the ACE enzyme, angiotensin converting enzyme, and also aldosterone is going to play a role in sodium being reabsorbed back into the bloodstream and potassium being pumped out. And antidiuretic hormone will play a role in retention of water, right, thereby decreasing the amount of urine formed. So please pay attention to the RAS system and know what the function of each of these hormones are. Moving on, bilirubin in the urine may be indicative of a disorder in the blank. Is it a disorder in the pancreas, kidney, adrenal gland, or liver? Which of the following do you think there may be a dysfunction if you have bilirubin in the urine? Okay, most of you picked liver, and that is correct. So we see that the presence of bilirubin is an indication in the urine is an indication of liver dysfunction, because when you have the erythrocytes being broken down, the heme group is going to be broken down into various substances, which eventually ends up as bilirubin, which will be lost in the feces. But if there's some liver dysfunction, bilirubin, rather than going into the fetus, it might end up in the urine, and it can also start accumulating in the other parts of the body, leading to yellowing of the whites of the eye, and this is known as jaundice. Okay, activating which of the following will most directly result in concentrated urine? Would it be renin, angiotensin, aldosterone, vasopressin, also known as antidiuretic hormone? Okay, most of you picked vasopressin or the antidiuretic hormone, and that is correct. So the term diuresis means to have an increased formation of urine, right? And so antidiuretic hormone is going to decrease the amount of urine formed, thereby making it concentrated. So antidiuretic hormone will act on the distal convoluted tubule and also in the collecting duct, and it will lead to the expression of aquaporins. These are channels which will permit only water to be moved across the membrane. So when you have more aquaporin expressed in the distal convoluted tubule and in the collecting duct, more water will be reabsorbed back, and as a result the urine will become a lot more concentrated and less urine is produced. Okay, so most of you were correct. Okay, next question. So the countercurrent multiplication occurs in the blank and thus helps establish the medullary osmotic gradient in the filtrate. So where do you think the countercurrent multiplication takes place? Is it in the proximal convoluted tubule, the distal convoluted tubule, nephron loop, or the vasa recta? Okay, most of you picked nephron loop, and that is correct. Let me explain why this is the case. So when you consider the two words countercurrent multiplication, we need to see how this is the case. So in the nephron loop, we see the filtrate is going to move down in one direction, and then it's going to move up in the opposite direction, and that's why you use the term countercurrent. And then we find that the term multiplication is indicating to the change in concentration of the filtrate. So as the filtrate moves down the nephron loop, the concentration is going to increase, right? And that increasing effect is going to keep on multiplying the more the filtrate moves down the descending limb. But then as the filtrate is moving up the ascending limb, there will be a decreasing effect to the concentration, and that this decreasing concentration will keep on multiplying. So it starts from 1200 and ends at 100. So because of this multiplying effect of changing in concentration, which happens in a countercurrent manner, that's why it's called countercurrent multiplication, and this takes place in the nephron loop, and this will help to maintain this medullary osmotic gradient in the filtrate, where you have a low concentration near the cortex, but and as you get down to the deepest part of the renal medulla, the concentration increases. Is this clear, folks? Yes? Is it clear? All right, thank you. So a decrease in plasma protein concentration will affect the glomerular filtration rate by most directly having an impact on the capsular hydrostatic pressure, the blood colloidal osmotic pressure, the glomerular hydrostatic pressure, or do you think all of the above will be directly affected if you have a decrease in the plasma protein concentration? Okay, most of you picked the blood colloidal osmotic pressure, and that is correct. And let me explain what's happening here. So we see that the glomerular filtration rate is going to be affected by 3 different pressures. The first one is the glomerular hydrostatic pressure, which depends on the pressure with which the blood is ejected from the heart, right? So that's what this glomerular hydrostatic pressure is based on, and this is the pressure in the afferent arteriole. And this pressure is going to be opposed by 2 other forces. One is the capsular hydrostatic pressure, and that is the opposing force expressed by the capsule, the wall of the capsule, as the fluid comes in contact with it. And the second opposing force is the blood colloidal osmotic pressure, and we see that as the filtrate is moved from the glomerulus into the renal tubules, the proteins will remain in the glomerulus, and the remaining proteins, they will exert an osmotic pressure to draw the fluid back into the glomerulus. And so if you have a decrease in the plasma protein concentration, this osmotic pressure drawing the filtrate back into the glomerulus will decrease, right? And so we see that the blood colloidal osmotic pressure will decrease, and eventually that will increase the glomerular filtration rate, because this opposing force to the glomerular hydrostatic pressure drops, and that will increase the glomerular filtration rate. Does this make sense? Yes? Okay. So BCOP is affected when you have a decrease in blood in the plasma protein concentration. Okay, injecting synthetic angiotensin 2 would most likely result in what? So as angiotensin 2 is being synthetically injected into the body, would it increase thirst? Would it increase the vasoconstriction? Would it increase blood pressure? Or do you think all of the above would increase, could likely lead to? Okay, all of the above is correct. So we see that angiotensin 2 does lead to increased vasoconstriction, and it can also cause more sodium to be retained in the bloodstream, thereby increasing the water retained. That will increase the blood volume, thereby increasing blood pressure, and so there will be increased blood pressure. And there's also an increase in thirst, which is due to angiotensin 2. It acts on the brain, and that can increase the thirst as well. So while at rest, a blank of the glomerular filtration rate is most dominant. Is it the hormonal regulation, neural regulation, autoregulation, or humoral regulation? So which of these is most dominant when a person is at rest? So autoregulation is correct. We find that, as shown in the slide here, that the when a person is at rest, autoregulation is dominant, and this means that if there's any changes in the filtration rate, there will be changes taking local changes will take place. Like there could be the afferent arteriole dilating if there's a drop in blood in the filtration rate, bringing more blood in. Whereas if you have an increase in the glomerular filtration rate, then the afferent arteriole could constrict, allowing less blood to come to the glomerulus, right? And accordingly, the efferent arteriole will constrict and relax as well. Okay, which type of epithelia would you expect to find in the external orifice of the urethra? Would it be simple cuboidal epithelia, simple squamous epithelia, stratified squamous, or none of the above? Okay, the right answer is stratified squamous epithelia, and we find that the external urethral orifice is going to be very close to the external environment, and it can experience a lot of physical abrasion and stress, and so to protect against that, there is the stratified squamous epithelia found there. Okay, moving on, which of the following carries unfiltered blood? Would it be the venules, afferent arterioles, efferent arterioles, renal vein, or none of the above? Okay, most of you picked afferent arteriole, and that is correct. So we see that unfiltered blood is brought to the glomerulus, and then once it leaves the glomerulus through the efferent arteriole, that is filtered blood. So everything beyond this point is referring to filtered blood. So that's why afferent arteriole is the only thing which brings in unfiltered blood to the nephron. Which of the following will become urine? Is it the tubular fluid, peritubular fluid, interstitial fluid, filtered blood, or none of the above? Okay, most of you said tubular fluid, and that is correct. So we find that when glomerular filtration takes place, the filtrate is going to move into the proximal convoluted tubule, the distal convoluted tubule, the nephron loop, and that filtrate is also known as the tubular fluid because it is the fluid inside these tubules, and that will eventually be will turn into urine. Whereas the peritubular fluid is referring also to the interstitial fluid, which is found around the cells which make up the parts of the nephron, the various tubules, and the filtered blood will remain in the peritubular capillaries. That's not going to turn into urine. Okay, columnar epithelium would most likely be found where? Is it in the proximal convoluted tubule, distal convoluted tubule, collecting duct, or the papillary duct or nephron loop? Where would you find columnar epithelium? So this should be a straightforward answer as well. So most of you said correctly, it is the papillary duct, because notice that this is the only one where you have columnar epithelium. Everywhere else it's either simple cuboidal or simple squamous epithelium. Okay, moving on, tubular reabsorption predominantly occurs in the proximal convoluted tubule, distal convoluted tubule, nephron loop, collecting duct, or in all of the above. So this is a question testing you on knowing whether you can remember what is the functions of the different parts of the nephron. Okay, most of you said proximal convoluted tubule, and that is correct. And we see that that once the filtration takes place, most of the reabsorption will take place in the proximal convoluted tubule, and to a small extent secretion can also take place. Whereas if you look at the nephron loop, you have different substances being reabsorbed, maybe water along the descending limb, along the ascending limb you have sodium and chloride ions, but it's most of it takes place in the proximal convoluted tubule, and that is why we see that there's an increased microvilli and also lots of mitochondria in the cells which make up the proximal convoluted tubule to give the energy necessary for the maximal reabsorption. Okay, moving on, which of the following has the least influence on the glomerular filtration rate? Is it the glomerular hydrostatic pressure, capsular hydrostatic pressure, or the blood colloidal osmotic pressure? So this is just not looking for exact numbers, but do you have a general idea of what are the three forces influencing glomerular filtration rate? Okay, so it is the capsular hydrostatic pressure, as you all pointed out. It's going to contribute around 15 millimeters of mercury, right, opposing the glomerular hydrostatic pressure. Okay, moving on, the concentration of filtrate, does it increase or decrease as it moves through the descending loop of to the descending nephron loop? So as it goes down the descending limb, what's happening to the concentration? Okay, most of you said it increases, and that is correct, because as the water moves, the filtrate moves down the descending limb, water is being removed, and because the descending limb is permeable only to water, and when you remove water from the filtrate, it gets more concentrated, and that's why its concentration increases. Okay, blank causes an increased expression of the sodium-potassium exchange pumps in the renal tubules. Is it renin, angiotensin, aldosterone, vasopressin, or none of the above? Which of these hormones can lead to the expression of sodium-potassium exchange pumps? Okay, most of you picked aldosterone, and that is correct. I told you that aldosterone is a steroid hormone which can get past the lipid bilayer easily, get into the nucleus, and it can trigger mechanisms to cause the expression of the sodium-potassium exchange pumps in both the apical surface and the basolateral surface of the cells, and it can cause more sodium to be moved into the bloodstream. Okay, abnormally high ketone bodies in the urine may indicate a dysfunction in the blank. So having high levels of ketone bodies, would it indicate a dysfunction in the liver, bladder, pancreas, or kidneys? So I told you how the urine can be analyzed to detect pathologies in different organ systems. Okay, most of you picked pancreas, and that is correct. So we see that if the pancreas is not producing sufficient insulin, right, as in the case of type 1 diabetes, then the body is going to use other substrates to make ATP. If glucose can be moved into the cells, then the body would start using fats, and one of the breakdown products of fats is ketone bodies, and ketone bodies, when they increase in the blood, they'll also end up in the urine. So that could be an indication of a problem in the pancreas. Okay, blank causes increased expression of aquaporin channels in the collecting ducts. Is it renin, angiotensin, aldosterone, or ADH? Okay, most of you picked ADH, and that is correct. We did discuss earlier how ADH leads to aquaporins to be incorporated into the distal convoluted tubule and the collecting duct, thereby increasing the water reabsorption. So in the remaining 20 minutes, I want to just go through the PollEverywhere questions from the respiratory system and the digestive system. And so we have already done this in class, so if you want to leave, you're welcome to, but if you want to stay and practice here, you can do that as well. Okay, so which part of the respiratory system is lined with both stratified squamous and ciliated pseudostratified columnar epithelium? This is the pharynx, trachea, bronchi, larynx, none of the above. Okay, most of you picked pharynx, and that is correct. So we see that the pseudostratified ciliated columnar epithelial cells, they're going to be found in the upper part of the pharynx, because that can help to trap particulate matter which comes in through the air. But then the lower part of the pharynx is shared by the digestive and the respiratory system, and because the incoming food could be abrasive, it could be too hot, it could be too acidic, whatever, that's why there has to be protection offered through the stratified squamous epithelium. So the right answer is pharynx. The mucociliary clearance is accomplished by the epithelium lining the respiratory tract. So is it the simple squamous epithelium, simple cuboidal, or ciliated pseudostratified columnar epithelium? Which one plays a role in mucociliary clearance? Okay, most of you picked ciliated pseudostratified columnar epithelium, and that is correct. So I told you how it is the cilia which is going to wave back and forth, and it can help to move the mucus up the respiratory tract. So this mucus can trap particulate matter, and then as it's moved up to the oral cavity, it can be spat out. Okay, an infection in which of the following would indicate that the lower respiratory system has been affected? Would it be an infection in the pharynx, or in the bronchi, or in the trachea, or do you think more than one answer is correct? Okay, most of you said more than one answer is correct, and that is correct, because bronchi and the trachea are part of the lower respiratory system. So we find that starting from the larynx onwards, it's considered to be part of the lower respiratory system, whereas pharynx and all the way to the nasal opening, it's part of the upper respiratory system. And I also wanted you to know the difference between the conduction portion and the respiratory portion of the respiratory system, because that is the functional divisions. Okay, which of the following can lead to forced expiration of air out of the lungs? Is it the contraction of the abdominal muscles, the contraction of the diaphragm, contraction of the intercostal muscles, or all of the above? So what leads to the forced expiration of air out of the lungs? Okay, most of you picked contraction of the abdominal muscles, and that is correct, because we see that the contraction of the diaphragm and the intercostal muscles, it leads to inspiration, right? It's going to increase the thoracic volume as you have the diaphragm contracting and moving downward, and also the intercostal muscles contracting and raising the rib cage. Whereas we see here that the contraction of the abdominal muscles, that's going to lead to forced expiration, right? And that's something you can actually control voluntarily. Whereas the intercostal muscles really can't control them. The diaphragm you can control it, but yeah, for forced expiration, it's the contraction of the abdominal muscles. Okay, according to the Planck law, the diffusion of oxygen across the blood-air barrier would depend on the difference in partial pressure of oxygen in the alveoli and the blood plasma. So is it Henry's, Dalton's, Fick's, or Boyle's law? Okay, most of you picked Fick's law, and that is correct. So, what is the law which determines whether air is going to flow in and out of the lungs? I want you to think about the air moving into the lungs and the path of the oxygen all the way down to the tissues, right? You can think of it alphabetically. So which law determines the inspiration, air going into the lungs? Boyle's law, right? Just think about alphabetically. So Boyle's law. And once the air enters into the alveoli, the question is how much of oxygen is present in the incoming air. So what law explains that depending on the elevation? Dalton's, right? So once the air is in the alveoli, and how much, what will determine how much of the air will diffuse across the blood-air barrier? Fick's law, right? Again, alphabetical order. And then once the diffusion across the blood-air barrier takes place, what explains how much dissolves in the blood plasma? Henry's law, right? Okay, so just keep that order in mind when in doubt. Okay. According to the law of Laplace, the pressure experienced by the alveoli sacs to collapse is inversely proportional to blank. So is it inversely proportional to the radius of the alveoli or the surface tension in the inner surface of the alveoli? Okay, so most of you said the radius of the alveoli, and that is correct. So if you notice this relationship here, so the pressure to collapse is inversely proportional to the radius of the alveoli. So the smaller the radius is, then there's a greater pressure of the alveoli to collapse. And so in order to offset that increased pressure due to a smaller alveoli, you need more surfactant to contract the surface tension. That's why the smaller the alveoli, it needs more surfactant. Okay, so that's what this law explains. Okay, which of the following statements is false about 2,3 bisphosphoglycerate? Does it cause a leftward shift of hemoglobin oxygen binding curve? Is the expression increased by low temperatures? Is the expression decreased by a low pH? Or is the expression a byproduct of aerobic respiration? Or all of the above are false? Or is it none of the above are false? Okay, most of you said all of the above, and that is correct. As you compare each of these statements with what is given in this slide here, you'll see that each and every one of those statements are incorrect. Okay, so the goal of 2,3 bisphosphoglycerate is to increase, to move this curve rightwards, which means it's going to decrease the affinity with which oxygen binds hemoglobin, and the goal is to ensure that your tissues get more oxygen. Okay, moving on, when hypocapnia is detected, the respiratory system will respond by increasing the rate of blank. Is it going to increase the rate of diaphragm contraction, the diaphragm relaxation, the intercostal muscle relaxation, or do you think all of the above will increase, or do you think none of the above will increase? Okay, most of you said none of the above, and let me explain why that is correct. So what is hypocapnia? What is hypocapnia? Low levels of CO2 in the blood. Thank you. I put the slide up here. All you have to do is read off of it, right? So low levels of carbon dioxide in the blood, and that is caused by hyperventilation, meaning that the rate of inspiration and expiration is very high. So to deal with this, the rate of respiration has to decrease, right? So because this question is asking which of the following should increase, none of them should increase. You should have a decrease in the rate of diaphragm contraction and relaxation, and also intercostal muscle contraction and relaxation. So that's why none of the above are true. Is this clear, folks? Okay. A leftward shift in the hemoglobin oxygen dissociation curve indicates that oxygen binds hemoglobin with blank affinity. So if there's a leftward shift, is it indicating a lower affinity or a higher affinity? Okay, most of you said greater affinity, and that is correct. And so when you think about this fetal hemoglobin and adult hemoglobin oxygen saturation curves, you'll notice that at, let's say, 20 partial pressure of oxygen of around 20 millimeters of mercury, you find that the saturation of fetal hemoglobin is around close to 70, right? But at that same concentration, you only have in the adult hemoglobin around 50% saturation. So a leftward shift means there's a higher affinity, and the rightward shift means there is a lower affinity. Okay, which of the following conditions affecting the binding between oxygen and hemoglobin, right, would increase the affinity and make oxygen less available to the plasma in the blood plasma? Is it a decrease in pH, or an increase in temperature, or an increase in partial pressure of carbon dioxide, or do you think all of the above or none of the above? So which will increase the affinity of oxygen hemoglobin binding? Okay, none of the above is correct. All these three things mentioned here is going to cause a rightward shift in the oxygen hemoglobin binding curves. Okay, next question. The chloride shift will blank. Will it aid in the transport of bicarbonate in the blood plasma, or will it take place in the red blood cells at the lungs, or will it aid in the transport of carbonic acid in the blood plasma? So which do you think chloride shift will accomplish? Okay, most of you said it will aid in the transport of bicarbonate in the blood plasma, and the term chloride shift and reverse chloride shift is only used in the respiratory system, right? So chloride shift is referring to the chloride ions moving into the red blood cell where the bicarbonate moves into the blood plasma. Now the reverse happens in the lungs, and so it's called the reverse chloride shift, where chloride leaves and bicarbonate enters the red blood cells. Okay, during expiration, which of the following take place? Would that be the elastic recoil of the alveolar wall be decreased? Would there be interpleural pressure being negative, or the interpulmonary pressure greater than the atmospheric pressure, or the interpulmonary pressure is same as the atmospheric pressure? So which of the following would take place in order for expiration to occur? Yes. Oh, let's see what most say. So most of you said C, and that is correct, right? So you said that the interpulmonary pressure is greater than the atmospheric pressure, and that is what is indicated here. So for breathing out, the PA, which stands for the alveolar pressure or the interpulmonary pressure, will be higher, and that's why air will move from inside the lungs out of the lungs, right? Yes. So the thing is, regardless of whether you're having inspiration or expiration, B will always be true, right? And similarly, that's why it really doesn't matter. The interpulmonary pressure is always going to be negative whether you're breathing in or out. The only time it gets positive is when somebody, what? Pneumothorax, when you have a puncture in the lungs and your lungs collapses. That's the only time this interpleural pressure will stop being negative. Can we move on, folks? Yes? All right. Okay, blank indicates the diffusion rate is proportional to the surface area for gas exchange. Is it Dalton's law, Boyle's law, Henry's law, Fick's law? If you don't know the different gas laws and how they explain what's happening in the respiratory system, please know that by 5 p.m. today. Right? You have a few hours. Okay, most of you said Fick's law, and that is correct. As you see here, the surface area being proportional to the rate of diffusion is explained by Fick's law. Which of the following is part of the conduction zone? Nares, pharynx, larynx, trachea, all of the above, or maybe none of the above. Okay, most of you picked all of the above, and I just want to say that with the exception of the respiratory bronchioles and the alveoli, everything upstream all the way down to the nasal cavity is the conduction zone. Now the purpose of the conduction zone is threefold, right? It's going to make the air ready for gas exchange by doing three things. It's going to make the air more humid, it'll make it warm, and it'll also filter the air. So without these three things, the delicate inner parts of the alveoli can be damaged. Okay, dysfunction of which of the following will increase the alveolar surface tension? Type 1 pneumocytes, type 2 pneumocytes, or the endothelial cells? Okay. Okay, yes, it is type 2, because type 2 pneumocytes are the ones which produce surfactant, right? And surfactant will decrease the surface tension in the alveolar surface, and if you don't have surfactants being produced, that will cause an increase in the surface tension inside the alveoli. Okay, so which of the following occurs in the systemic capillaries? Is it the Bohr effect or the Haldane effect? So systemic capillaries is referring to the blood vessels down in your bowels, in those tissues. Okay, most of you said Bohr effect, and that is correct, right? So Bohr effect is just saying that because of the decrease in pH due to the high levels of carbon dioxide, oxygen will bind to hemoglobin with less affinity, which is what you need so that the oxygen is delivered to the tissues. Whereas Haldane effect takes place higher up in your respiratory system in the lungs, and that is going to explain that oxygen will have will bind to hemoglobin, and that will decrease hemoglobin's affinity for carbon dioxide, right? And so that's why hemoglobin can readily bind oxygen in the lungs. Okay, which lung is thinner and longer to accommodate the heart, left or right? So it is the left lung because it's got this cardiac notch. Okay. So let's do a couple of questions in the digestive system. So let's okay, eating a high fiber diet will not help prevent which of the following? Will it not help prevent constipation, diarrhea, diverticulosis, hemorrhoids? Okay, the right answer is diarrhea, right? So diarrhea can be prevented by having electrolytes and also replenishing the water content, whereas constipation, diverticulosis, and hemorrhoids can be prevented by having a high fiber diet. So one of the consequences of celiac disease is blank because colonic bacteria break down the sugars that were not digested and absorbed in the small intestines. Okay, so folks came in prepared with the answers. So floating and it's floating stools and bloating. I switched this up. You don't float when this happens. You have floating stools and you feel bloated, right? So we find that the gas which is produced as a result of the fermentation in the colon, that will cause you to feel bloated, or the stools will start floating because the gas is infused into them. Okay, so Which of the following is a disaccharidase? Read the question carefully. This is change here. Disaccharidase, not disaccharide. Okay, what's the right answer? Okay, the right answer is actually B. So sucrase is the disaccharidase which will break down sucrose into fructose and glucose. All right, so I said disaccharide here, should be disaccharidase. So in this case, the answer is sucrose. Okay, thank you all for your time, and I will see you later tonight, and I wish you the best for exam 4.